Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Scott MacLean has extensive experience as a lecturer and in practicing implant dentistry. In this episode of Practice Inspiration, he provides details on how to successfully plan dental implants in the mandibular arch.
Hello, I'm Dr. Scott MacLean, and we're going to be discussing some very interesting treatment planning. We're going to be looking at the molar implant and looking at how do we plan this particular area of the mouth to get a very effective and very good kind of outcome. If we look at this particular implant, we can see what I like to choose is something that has a platform shift. And we can also see inside, it will have a conical connection, which is usually a great thing to have on a posterior implant. And lastly, we can see down inside of here, we can see a hex, which is an anti-rotational hex. So this particular implant is new to the market, but I like this particular implant because of the features and benefit it offers. If we look at the thread pattern itself, it starts having a very knife edge thread at the tip of the implant, going into a knife edge with a particular square area, and then at the top, going into a square. So as this implant goes in, it actually is going to act like an osteotome, making a lot of grab. So if we're going to do this implant immediate or through a traditional stage, then it's very important to have these guided threads. If we look at the top, it has a kind of a micro thread, which puts less pressure on the bone. So I choose this particular implant for a number of reasons, but one of the main ones is the stability I can get when I'm doing the implant at the time of surgery, but also having the amount of force. So this implant has a fatigue strength that's double that of its predecessor, which is a regular platform implant. So we go from 290 up to about a 580 Newton centimeter when you're loading this off axis, which means it's going to be stronger for the mouth. If we look at this particular case, this is a case I did a few weeks ago. So if I look at this particular case, we can see that the molar is non-restorable. This patient came into my office in the morning and is a radiologist, and so wanted to have this dealt with right away. So rather than take the rather than take the tooth out and leave the patient, I'm going to take the tooth out, place the implant, and get this into a very minimal amount of bone with a high kind of success rate. So this implant is able to generate a high torque up to 60 newtons in this particular case, which is more than enough to have this stabilized for long-term success. So once I place the implant, then I'm going to be starting to do the process of creating emergence profile. So by putting on a healing abutment, you can see here I've left it to be a little bit see-through, and the translucency shows this emergence profile going from the top of the implant up, which creates a cuff of tissue. We're going to look at this a little bit closer by just examining this particular implant. But look at this particular case. We can see I'm putting the implant in a little bit deeper than you would actually think. We want to be 3 millimeters below the free gingival margin on these cases, and then planning to stay close to the sinus, but this implant is using minimal bone to get a real great grab. If we go to the lower, we can see the same kind of process. This is a lower that I've placed, and you can see that the bone around these particular implants is staying. So let's have a little particular look at the implant and do some planning so we can take a case and take it to the final completion. So we look at this particular case. Most times we're used to dealing with implant planning on a two-dimensional type of planning software. If we go to a 3D planning software like we're showing here, we can see that there's a number of things that we can look at that are going to be beneficial to placing this implant. So number one, dentists are very into finding out where this nerve is. And most 3D softwares will do this for you. And so I'm mapping out the nerve here. You can see I'm showing the mental foramen. And as I go to the mental foramen, I must not forget that there might be an incisive branch in the anterior aspect. So planning this forward, whether you're doing the surgery or you're having another surgeon do it, we have to kind of work as a team. So as I look at this case, I can now do what's called a smart fusion. So bringing a model back that was scanned at my lab, I can bring it back in and put it into the 3D imaging software So I'm able to see both the model and the 3D image at the same time. So I can check out how thick the soft tissues are on the buccal lingual. I can also see the bone. I can see the buccal bone. If you look down in this particular aspect, it's quite thin on the buccal. So if we go to the lingual, we can actually see that the lingual bone is very thick. So we have to kind of use this information to plan the case. So that's one of the things I look at, and that's the tooth that we're not going to be working on. We tip the particular software window, the editor window, with this particular tooth, and then we're going to move back. So as we move back, we can see we're taking this particular window to where we want to place the implant in this particular case. So I can see now where I want the crown to be right here in the red. I can see how thick the soft tissues are on the buccal, and I can also see the thicker tissue on the lingual. So after the tooth is removed, this anatomy stays very similar to what we're used to. So if I take an implant now, I'm going to show where I want the implant to be. I'll click 2 different spots, and I'm going into the menu to try and kind of pick an implant out of the system. What you'll notice here is that there's a new button in this particular software, and it's the wide platform button, which is going to be the new Emergence Profile, and the bigger implant, which has the double strength. So this particular implant is 5.5 millimeters wide. We can see it has double the strength, which is, I like this, and I like the fact that it's going to have a better Emergence Profile. So if we're showing this implant, we're going to take it and look at it actually in the bone. We can see a number of things that we can't really see when we're doing a traditional 2D look at a pan. So first off, I can notice that I'm going to pick an implant so it's not going to come out through the lingual ridge. So I mean the undercut underneath the implant. So you can see underneath this implant is this undercut right under the tongue, which means that if I pick an implant too long, it's going to deflect the implant or it's going to go through this particular bone. So we want to kind of stay a little bit short of this area. Now if I rotate around the implant, look at how far back this implant is relative to where the crown is. This would create an unfavorable Emergence Profile. So what we want to try to do is to make the profile good. So we'll move the implant a little bit tighter, and then we'll have a look at this as well from a safety point to the nerve. Now that we've mapped out the nerve, we can see where this implant is going to be relative to the nerve, relative to the soft tissue, because we want something to fit in between the two. So I'm measuring the soft tissue here. I'd like to have 3 millimeters of soft tissue as my minimum. Here I'm showing 2 based on research. But if I get that 3 or more, a little bit more, I can create that Emergence Profile plus the soft tissue seal around the top of the implant. So if you'll notice, I'm moving the implant down. Now I have to adjust my measurement from the nerve. So I can easily do this prior to surgery, which is the critical part because I don't want to be doing this at the time of surgery and being worried and kind of losing some sleep over this. So my goal is to place this implant on the computer, so I'm actually doing a virtual surgery, but also doing a virtual prosthetic workup. So as we look at this now, we can also look for where I want to do my incision. I want to take the tissue and move it from the lingual to the buccal, making sure that I'm taking that tissue to make it thicker. I don't want to punch that tissue away. I want to take that tissue and use it in a different spot. We can also look at the prosthetic space. If I measure down from the top of the crown to the top of the implant, you'll see it's 10.4 millimeters here. This is the prosthetic space, more than enough to place an implant crown in this particular situation. If I look at the bone width, I want to have at least 1.5 to 2 millimeters on the buccal and also on the lingual. So we can do that. We can see that we've got ample bone here to place this implant. But you will notice that the anatomy of the bone is very typical, that the bone is kind of sloping from the buccal to the lingual, so less bone on the buccal. So what I like to do sometimes is to take a line, draw the Emergence Profile of the crown in one dimension, rotate around the implant, and then come back and have a look at this particular position of the Emergence Profile. I am all about Emergence Profile in these implants. The Emergence Profile is kind of like the missing link to making the soft tissue work well. So if we look at this particular case now, I can see the implant in the bone, I can see the soft tissue and how it's going to look. Imagine if this was a gold crown. This would be a lot of gold to make a crown like this going on top of an implant. It's not like a typical crown, which would be a shell going over. It's actually the whole thing. So it's like the bone, the soft tissue, there's a lot of gold. But now I'm going to evaluate one of the #1 problems people have is Emergence Profile keeping a food trap in front of the implant or behind the implant. So we can create the emergence coming up from the implant then that enables us to have a really successful case for the patient. So by having a wider implant, why not go wider? That's the question. Why not go wider? If we go too wide, it's the buccal lingual dimension that limits us, because we don't want to go too wide and come out of the buccal plate or have limited soft tissue cuff around. I want to have that 3 millimeters of soft tissue cuff around this implant. I feel that's what's generating success with the platform shift and the conical connection. So if I look at the case, I can now see I'm going to bring extra tissue into this area from the lingual, bringing it to the facial aspect, and this is going to make it so that this case is going to be successful long term. We're going to lose very minimal bone around this particular implant. I've placed a number of these now, and this is working very successful for my practice, so it's been great for the patients. Watch what happens when I take the implant and push it distal. All of a sudden, the emergence profile is not going to be favorable. And you're going to find that food's going to trap in here. We're going to have extra lunch later on in the afternoon every day. Patients will not like this. They'll be very disappointed. And so we want to put the implant in the right position. But also look what happens when I place it not deep enough. If I'm not deep enough, again, the emergence profile is going to make this undercut that's going to cause us to have issues with the soft tissue. So the soft tissue is not going to seal it off. You're going to have a little bit of bone loss happening around it. So placing the implant is important. Now I can check this out in 3D. I can see the nerve falling underneath. I can rotate it around, see the soft tissue emergence profile. I know that we have this big, bulky implant underneath that is going to serve this patient for long term. I think for the life of the patient. So this is important. If we're looking at the particular crown, this is now based on prosthetic planning. So the implant surgery is done because of the prosthetics. So we could put an implant anywhere. We could put an implant in the knee, but if there's not an ability to put the tooth on and have it working, then it's not going to be effective. So now the next thing I like to do is to pick an abutment. So we're going to pick what's called a peak abutment. So a polyether ether ketone abutment. It's a lot to say, but it's if you call it a peak abutment, it's an acrylic type of abutment, plastic, and it kind of has an emergence profile that's going to take us from the implant out to the contacts on either side of this particular case. So when we're doing this, we are able to also choose our typical titanium abutment that everyone's used to. So if we want to have that as well, just look what happens when I put the emergence profile based on my kind of computer model. I can see both are going to work to make sure that we seat the crown down. It's going to be a good case to finish on. So it's not going to have a lot of pinching, a lot of soreness or anything like that when I go to put the crown on, and the patients like that. And doctors that are placing the crowns also like that as well. So look at this. This flared emergence is the ideal type of position. We're coming from an implant that is 5.5 on the outside, 5.1 on the inside, so 5.1 out to 11 or 10, 12 millimeters, we get this ideal emergence, particularly if we have the implant at the right depth. If we just go bone level, we won't have the right depth. So let's look again one more time at this particular case. We can see that, number one, we can see where the nerve is. This is critical. Number two, we can see the soft tissue cuff. We can see that that's ample, so I'm going to have my 3 millimeters. We can also see the wax up and where this is going to be from a prosthetic space, from a particular incisor, where I'm going to take the cut and make the cut of the tissue. So I'm going to make the cut based on anatomy of the soft tissue. We can't see soft tissue usually on these CT scans. Then we can also look at where the incision line is I was talking about. There's the incision line. I'm going to move the tissues to the facial. Also the bone width. We can see the bone width on these cases. So there's a lot of information here. Last, we can see this lingual undercut. So if I'm looking at this case, I'm looking at it from a three-dimensional case with either if you're doing the surgery or someone else is doing the surgery, whether you're doing the prosthetics, it's a great blend. The lab can be involved, your referring dentist can be involved, and plus you can be involved in this planning. Push a button, look what comes out. A guide to place this. 2 words in implant dentistry, depth and angulation. This controls depth and angulation of the implant to put it in the exact spot that we need, which is critical for long-term success. If we look at another case coming up, we can see that in this particular case, just to finish on, we can see here's a case that a patient came in, wanted to have a molar, so we're worried about this, so we do a guide. We want the guide so we get the tip of the implant exactly where we want to be in the bone. So once the tip is placed, we know that the tip of the implant is 4 millimeters. So I want to underprepare that aspect, but I want to have a hole or an osteotomy going through that's 4 millimeters and then not prepare too much underneath this. If I take the case to final, we can see that once the peak abutment is put on place, this is going to allow the healing, so that the healing is going to be made to have the proper emergence profile. So once the patient comes back, in this case, they had an ASC abutment standing for angulated screw channel. It's all idealized, so we want the screw channel to be where we want it to be. You can see the OmniGrip screw on top of this. And finally, when I fill this in, look at where it goes. It looks exactly like a tooth. We can't see a channel on here. Patients are not concerned about this. So it's a very fabulous type of system. We can see here, finally, on the x-rays that placed in the implant to when I take the impression, the bone is staying at the top of this implant, which is the ideal position. So I'd like to thank you on behalf of you tuning into this particular video, and I hope you enjoy some more from the Seattle Study Club.